Hi, good evening, everyone. Thank you for joining us. This is Dr. Alvarez here. Some of you know me from prior consults or encounters in the clinic. We are extremely lucky at IR Centers at AMP to have our Chief Medical Officer joining and one of the leading experts in the topic at hand. I'm going to let him take away the presentation here, and I'll be answering questions in the chat box if I can help anything.
Okay, thank you, Dr. Alvarez, and thank you everyone for taking time out of your evening tonight to learn a little bit more about treatments for BPH. Specifically, tonight we're going to be talking about a minimally invasive or non-surgical approach for BPH called prostate artery embolization, which, as you'll see in this talk, that many patients will suffer from BPH. So, without further ado, we can kind of get into the talk. Um, like Dr. Alvarez said, we're IR centers and we specialize in minimally invasive procedures to treat benign enlarged prostate. Um, we do other procedures as well, including procedures in the musculoskeletal space and also the GI space. But both Dr. Alvarez and myself, we're minimally invasive specialists or interventional radiologists. So what that means is we've trained in diagnostic imaging, but then taken it a step farther, where we implement some type of therapy using imaging as a guidance. So that may be CAT scan or ultrasound or MRI or fluoroscopy or live X-ray. Um, so a little bit of background on tonight's topic, BPH or benign prostatic hyperplasia. It's very common. Up to 15 million men in America are affected by it. At 50% of the men will have BPH or BPH symptoms. And at 80 years old, almost 80% of men will have it. So it's almost ubiquitous across men as they age. And what that may present as is frequency or the feeling of when you need to go, you got to go and you got to find that toilet right away, weak or slow stream, difficulty starting, initiating or dribbling, waking up at night to go to the bathroom. That symptom there is often underrepresented because some men will say, "Hey, I wake up at night, it's no big deal," but they don't realize that how that impacts kind of their overall health and energy levels throughout the day. Um, Feeling that the bladder never empties fully. And some patients may have BPH and not really have many symptoms, and their first presenting symptom may be that they just can't pee on their own and they need a catheter. Um, so this is kind of going to a little bit more detail, but what is BPH? So basically, it's enlargement of the prostate, which the prostate's a gland that sits around the urethra or the channel that drains the bladder. And it can grow. It can grow into the bladder and can also strangulate or reduce the caliber of that urethra or that tube that drains that bladder, which causes to these symptoms as we discussed. So prostate size. Some of you may have already gotten your size on an ultrasound or a CAT scan or an MRI. But this is not necessarily to say, oh, if you have a really big prostate, your symptoms are the worst. And if you have a really small prostate, your symptoms aren't a big deal because we have patients with a smaller size prostate, about 30, 35 grams, and they can come in urinary retention not being able to pee on their own. And then you have someone with 100, 150-gram prostate may come in and they say, yeah, my symptoms aren't that bad. So it's not necessarily the size itself. But just to give you an idea, a normal size prostate's about the size of a walnut. That's going to be about 20 to 30 grams or cc's. A ping pong ball, now you're talking about a little bit bigger. Golf ball size, it's about 40 grams. I would say most of the patients we treat are usually somewhere around that 60 to 100, 150 gram size. So somewhere around a clementine or a tennis ball, but there is no upper limit of size for performing a PAE. And we'll go over some of the other treatment options and the describe PAE in the context of that. So excuse me, that dovetails into what are your other treatment options? What are the treatment options available to patients? So a lot of times medications will be the first thing that are offered to you guys. Alpha blockers or 5-alpha reductase inhibitors. So alpha blockers are like your Flomax, Um, the 5-alpha reductase inhibitors like your finasteride, dutasteride, um, they can help with symptoms if they're taking daily and for the long term. But it's common to have side effects. Some side effects may be hypotension or low blood pressure. It can be retrograde ejaculation or sexual side effects. And sometimes there's definitely a push within the urology community to get patients to a more definitive therapy sooner because these medications aren't without their own risks. Then you step over to that next bucket, um, which PAE is included in, but minimally invasive options. So that includes Urolift, which basically I'll have a picture on that or a video on that on I think the subsequent slide. But basically, they open up the channel using a mechanical device. Rezūm, where they use steam or water vapors to enucleate or shrink the prostate. PAE, which will be the topic of discussion today. Um, and then you have your surgical or even resective technologies or procedures. So TURP or transurethral resection of the prostate, that's where they put that rigid metal device up and they kind of carve out the prostate. There's newer technologies like HOLEP or holmium laser, which carves out the prostate as well. Um, Aqua ablation, where they use a high-powered heat-free water jet to remove prostate tissue. And then obviously PAE. Now, it's to keep in mind, all these procedures treat benign enlarged prostate, but they're all some level of durability. I mean, they last us some period of time. And some of the more durable of those resective procedures have their own risks, like anesthesia risks, sexual side effects, incontinent risks. So you're always weighing the risk benefit when you're trying to select which treatment might be right for you. So this is just going into a little bit more detail. We talked about alpha blockers like Flomax. We talked about some of the side effects that you may have. Could be dizziness or low blood pressure. Also potentially or erectile issues or ejaculatory issues. The finasteride or 5-alpha reductase inhibitors also have their own sexual side effects, including like issues with libido. Um, but can work. Both can work really well for prostate symptoms, though. And then always to keep in mind is lifestyle changes. Some of the biggest things is fluid intake, alcohol, caffeine, spicy foods. Those are some of the bigger ones that can impact just like urinary or bladder health in general. So we talked about some of these treatment options. So Urolift, PAE, Rezūm, aquablation. So here in this top left corner, you have what's the Urolift, where they basically go up. It's an office procedure. They go up the penis. They'll use this device and basically open up that channel using staples or essentially sutures to kind of pry it open. It works well. There's an upper limit of gland size, which this kind of works with. And then also the shape or morphology of your prostate may be limited. So if you have a median lobe, it might not be the best option. This is Rezūm, also upper limit size restrictions, but they basically use that steam technology or water vapor to try to help enucleate the prostate by going up the urethra and directly injecting that steam. And the bottom two is your aquablation where they use an ultrasound probe, transrectal ultrasound probe, to give them the shape of the prostate. And then they put this device in, which is basically like a power washer, and that ultrasound will help them resect prostate tissue. And their margins are very precise because of this. The advantage of doing it this way is that your your margins are very precise, and um, when you don't use thermal energy, your margins are exactly where you leave them. Drawback here, though, is there can be some bleeding. And oftentimes we actually will do PAE in combination with this aquablation. Um, so let's see here. So what should you know about PAE? So um, procedure itself can take anywhere from 1 to 2 hours. Usually we say about 60 to 90 minutes start to finish, can be a little sooner or a little quicker. Success rates, clinical success rates are expected over 90%. So in the literature, it's about 90%. In our practice, it's even higher than that. And what that means is a greater than 50% reduction in IPSS score with patients with moderate to severe lower urinary tract symptoms. There's no hospital stay associated with this procedure. It's an outpatient based procedure. You come in and you go home the same day. no general anesthesia required, no surgical incisions required. We do it all through a tiny pinhole, which I'll go into a little more detail. So could PAE be right for me? Is it the right option for you? Now, all these things will help decide whether or not you should be going for a treatment for your prostate. I will say there isn't an absolute contraindication, meaning there isn't any one thing that would say no, you absolutely cannot have PAE. But things that we look for are confirmed enlarged prostate. With it may be a clinical exam, it may be a clinical evaluation, like I mentioned, the IPSS, which is related to your symptoms related to an enlarged prostate. You've been on medication, the medications aren't working adequately, or you've been experiencing side effects that you're not happy about. Moderate to severe symptoms of IPSS or urinary symptoms. You wish to preserve sexual function. Some men don't even want to go on the medications, or they don't want to have these other treatment options because they 100% want to preserve sexual function, and that be the reason why they would want to go for PAE. Prefer overall to just avoid surgery or higher risk procedures. This definitely will be probably the lowest risk profile of all the procedures. And no prostate cancer concerns. Now, this one I put a little asterisk, and I'll go into detail a little bit more about this later on in the talk. But PAE is not a treatment for prostate cancer. It does not increase your risk for prostate cancer, but we can't say it's going to help treat your prostate cancer if you do have prostate cancer. So how does the PAE or prostate artery embolization work? So basically, as I mentioned, it's a day procedure. All in all, you're with us in the office for about 3 to 4 hours. You get there about an hour before. Procedure itself probably takes about an hour, and you recover for about 2 hours. But basically, what we do is we access at the blood vessel at the top of the leg. We can go through the wrist, but typically we will go through the blood vessel at the top of the leg. It's shorter distance. And for a few reasons, it can be a little bit safer in specific patient demographics. Um, but without a big incision or anything like that, we'll go through a little pinhole, the blood vessel at the top of the leg. We'll use the blood vessels as basically roads to go to the prostate, utilizing live X-ray or fluoroscopy as guidance. And take basically a thin, flexible, hollow tube, which in medical term is catheter. It's thinner than a piece of like angel hair pasta, super thin. And we'll go to the blood vessels that supply the prostate. We'll take pictures using contrast dye to map these blood vessels out. And then once we're at the prostate, we will block off the primary blood flow using these tiny little microspheres made of this biocompatible material, which are permanent. And then typically behind it, we'll pack it in with a foam-like material called gel foam. Um, this will eventually cause shrinkage and softening of the prostate over time that will allow for easier passage of urine and help with urinary symptoms. When we're done, we remove the catheter, we close that tiny hole, and then we put a Band-Aid on, and you go home that same day, as I mentioned. You can't drive because we do this under what's called moderate sedation, or kind of like it's almost like a twilight sleep. Um, so you will need a ride. So here's just a cartoon schematic of what is actually happening. So this is this white tube that you see on the screen here that's going into that red blood vessel going towards the prostate. That's the catheter that I mentioned. And these tiny little round balls are a cartoon version of that. So here's us. We can hop on the magic school bus, and this is a cartoon of displaying. We can be super precise, avoiding the bladder, which that's what's up there at the top of the screen, and then deliver it strictly to the prostate. Now, it doesn't shrink in real time like that. I wish it would, but it does shrink over time. So this is actually what we see in the lab. So on the top left screen, that's actually just that little portion is actually exposed, and that's where we have our little catheter, and that's where we inject the contrast. So that's really all it is, the little pinhole. And then the live X-ray or fluoroscopy is showing us navigating to that prostatic artery, which is that twisty, tortuous one that's going towards the bottom center of the screen. So all that blush is what we call, or that gray smudgy area, is an enlarged prostate. So we can see very clearly that's where we are, that's our target, and then we will administer those tiny little embolics or those beads to treat that. So your recovery after PAE and what to expect. So we talked about the day of the procedure. Go home that same day. You need that ride. You might feel mild soreness at the access site. As I mentioned, we typically go through the groin or the top of the leg. We encourage patients to drink plenty of fluids, um, hydrate well, and then we will prescribe. We have a medication cocktail that we give you, which includes an NSAID or ibuprofen, a steroid, or Medrol dose pack. Because we're giving both of those to you, it's kind of harsh on your stomach. So we'll give you anti-reflux or acid stomach medicine, an antibiotic, and then also this medicine called Pyridium, which may help with any type of burning on urination that you may experience. And the reason we do that is because there is a period, and I have this on the next slide, where you may experience some increased frequency for about 2 to 4 days. So in the first week, you're essentially going to feel like your normal self. We say light activities are perfectly fine. You can shower the next day. What we do ask you to avoid is heavy lifting or strenuous activity or exercise for 1 week. And that's really more so to allow that tiny hole that we went in, but we do close to heal up properly. We do a follow-up call with you, usually within the first 24 to 72 hours to just to make sure you're doing okay. And then around 2 to 4 weeks, you'll be fully back to your normal activities by the second week. Um, you resume sexual activity, but you'll start to notice your urinary symptoms improving probably by the second or third week. As I mentioned, the first 2 to 4 days, they may actually increase in frequency, normal to be expected. Um, your symptoms will continue to improve up to about 3 months. 3 months is where you will reach basically your new steady state or how you're going to be from this procedure, which is great. That's where you will get your maximal reduction in size. Typically, with PAE, most patients will have somewhere around 30 to 40% total volume of shrinkage of the prostate gland. With that being said, it primarily affects the central portion of the gland, which is actually more impactful in opening up that channel. Um, we discussed results with you after that as well. And at that point, about 3 month mark, we usually like you to follow with the urologist. So included in this normal recovery, I mentioned this earlier about that. Here it lists as 5 to 7 days. It's more like 2 to 5 or 2 to 4 days where that increased frequency, increased waking up at night, might have slight burning on urination, maybe have even a slighter weaker stream. I put retention here with asterisks because after PAE, we do not place a catheter in the vast majority of men, 99% we don't place a catheter. Now, patients who have gone into urinary retention, meaning they can't pee on their own and they need a catheter to pee on their own within the last 40 to 45 days, or they have a very high post-void residual, meaning they're not emptying their bladder, and we know that. We do recommend, or we can advise. Oh, sorry, I don't know where that jumped forward. We do recommend or advise placing potentially a catheter at that time, but vast majority of men won't need a catheter. So outcomes, expectations, and what does the literature and evidence say? So of all the procedures or minimally invasive procedures for benign enlarged prostate or BPH, PAE has the most evidence. It has level B evidence by the AUA, which is the Urologic Society, same as the other missed therapies. 8 randomized controlled trials, which is basically what we consider our gold standard, comparing it to TURP, which demonstrates substantial symptomatic reduction with less adverse events with TURP. It typically will reduce the IPSS score in moderate to severe LUTS by 11 to 15 points. The mean durability, so I kind of touched on this earlier, that any procedure you do short of total prostatectomy, you'll have some degree of recurrence over some period of time. With PAE, though, it's about 5 to 7 years. So we put it in the kind of moderate durability range here. Can last longer, may last shorter. But in all comers, it's going to be about 5 to 7 years. It can be repeated. It also doesn't preclude you from any other treatment for the prostate in the future if you elect to do so. You may be younger, healthier now, and you say, hey, sexual function is really important to me right now, but maybe in 7 years it's not, and I want something that lasts longer afterwards, and that's the last thing. You may go for a PAE now and then go for a HOLEP when your symptoms may return, if your symptoms return in 7 or 8 years. Um, PAE has no effect on erectile function or ejaculatory function. You may see transient hematospermia or blood in the semen for a few days to a couple weeks, which will resolve on its own. What results can you expect from PAE? So this is just kind of reiterating or summarizing that last slide. But yeah, over 90% of men are going to report meaningful improvement in symptoms, and we talked about what that reduction would be on that last slide. Durability we touched on about 5 to 7 years, 3 to 6 weeks before you will notice improvement, but it'll be maximal improvement at around 3 months. After a successful PAE, patients will have their prostate shrink. Here it says about 20 to 40. I would be a little bit more optimistic about 30 to 40% in total volume, as we mentioned. Um, Important things to know, results may vary. It's not a nothing in medicine is 100%. So there is that 10% who don't improve the way that we would hope or like, but that's with any treatment for an enlarged prostate. As I mentioned earlier, prostate cancer does not treat PAE does not treat prostate cancer. And it's ideal if you have elevated, if you've been following with your PSAs and you have elevated PSA, that um, get that worked up appropriately. Um, and we talked about after 5 to 7 years. So insurance coverage and what to expect. As I mentioned, the societies all support PAE, and it's not investigational. But that has helped with medical coverage by payers. It's covered by Medicare. It's covered by most commercial payers. What's great about for Dr. Alvarez and myself, we work with a team who has a team dedicated to interfacing with the payers or the insurance companies. So we don't have to do anything. You guys don't have to do anything. The team will do that on the background. And you know what, if anything, you would owe prior to coming in for the procedure. Pre-procedure preparation. Some patients, very rarely, they'll do a CT angiogram prior to the PAE to map out the anatomy, but vast majority of time that is not necessary. We may instruct you to hold any blood thinners that you may be on. Um, this can be performed while patients are on blood thinners. It is probably the safest or lowest risk procedure. So sometimes patients have fresh cardiac stents or stents in the heart, and they can't come off those blood thinners. So all the other procedures are not really options for them. But for this, we it's okay because we do use that closure device in the holder. We make it so tiny we can perform it while patients are still on blood thinners. Day of the procedure, wear comfortable clothes. The you don't have to. We tell you not to eat or drink anything after midnight, and that's more so for the sedation that we give you. We don't want you to aspirate or have those contents go up into your lungs. That would be bad. And we'll give you discharge instructions after you go home. You get Dr. Alvarez's cell phone number, or Dr. Kumar, his partner. So there's two physicians at the Syracuse practice, but you
We have
get their
three
phone numbers.
physicians now with Dr. Goldberg also.
Correct.
Yeah.
Dr. Goldberg as well. Thanks for adding that. Yeah, and then we'll typically follow up the next day. So I don't know, Daniel, maybe you want to take some of these questions here. These are common questions that I get asked, but I'm sure you get asked from patients this all the time. But
Yeah.
yeah,
Mhm.
so maybe what do you say when patients ask, is the procedure painful?
Well, as any other medical procedure, there is a component of pain, although the pain is minimal. So much so that in certain instances, some practitioners perform it only under local anesthesia, which means a pinch and burn at the access site, typically the groin. You may find out there in the internet that it can be performed through the wrist or through the groin. This is true. Our preferred method with most consistent results is through the groin. And we do administer this. It's called lidocaine or novocaine, the same thing that dentists use. We use it to numb the skin and the groin. And when we pinch you, you do feel a small amount of pain. Afterwards, the procedure it really doesn't, you don't feel much while we navigate inside of the vessels and we get where we want to get. At the end of the procedure, very rarely if the prostate is too large, as it asks for blood and we stop the blood from getting into a prostate, you can have a small amount of pain. And we have actually a good amount, we have good measures for that. We utilize intravenous medications for pain. This is known as moderate sedation. And this is one of the reasons why you can't drive the day of the procedure. And that would significantly reduce the pain. Also, since we work in high flow vessels in the arteries, at the end of the procedure, we do need to hold pressure at the access site, which can be uncomfortable for some patients. However, the level of pain and how uncomfortable you are doing the procedure, comparing PAE against other minimally invasive therapies or surgeries, significantly less.
Yeah, that's great. Yep. How about this? What patient asks you, will I be able to, or when will I be able to stop my prostate medications that I've been on for the last 10 years?
Right. So most patients actually end up being able to discontinue the medications. Some patients just to reduce the dose of the medications. And thinking about that graph that Dr. Pabidapa demonstrated in one of his slides, there is an acute inflammatory response, a little bit of swelling in the prostate the first week, and it continue, and afterwards it shrinks. Right at the 1 month mark, we already see results. At the 3 month mark, we see probably 95% of the results. So as time goes by, it becomes easier and easier for the bladder to empty urine across the prostate. So it's not immediate that you can stop medications, but most patients tend to be able to stop the medications altogether. And my advice typically is to stop those types of medications gradually, as opposed to suddenly.
Okay. How long, and I kind of touched on this a bit, but what do you tell
Yeah.
patients when they ask, how long will it be before I notice improvement in my symptoms?
By 3 to 4 weeks. By 3 to 4 weeks, you will notice some improvement. We'll give you a phone call and make sure you're doing well. However, you will continue to get better and better. Yeah.
Okay. And I think this one we kind of already addressed, but we do not have
Mhm.
to go to the through the penis to perform it. What about when describing risks? I kind of alluded to the safest procedure or lowest risk procedure for your prostate, but what risks do you mention to patients and how common are those risks?
Right. So I divided types of risks associated with the procedure in two. Some of them associated with the access site in the artery that we utilize to get into your system, and others associated with the prostate itself. So the risks associated with the access site, I mentioned they are as high as 2%, and I know it's lesser than that in our practice, but there is literature out there mentioning that it can be as high as 2 to 5%. So to keep it generous, I say 2% or less. And it has to do with a bruise at the groin access site. Sometimes you get a little bit of a bruise or an injury in the arteries altogether. More specifically in the femoral artery, which is the one that we use. Now it's very rare, but that's the most common one, I would say, out of the potential risks and issues. Now it is exceedingly rare, but it can happen that some of the particles. Now let's talk about the prostate. Some of the particles that we administer in the prostate escape into adjacent little vessels, giving you an ulcer in adjacent tissues like the rectum or the penis. This is less than 1% based on evidence from 2016. It was around 0.2%. More recent evidence, including a review of over 9,000 patients published in 2025, revealed a number under 0.01%. So those are the risks that I typically discuss.
Yeah, and we published that, yeah, our up to 9,000 pages. So just for context, and Dr. Alvarez isn't going to say this, but as a practice, we perform the most of these procedures in the country or in the world. We do thousands of these, probably close to 30,000 of these across all our centers each year. Um, how long will the results last? Kind of touched on that, so maybe we can move on to the next
Well,
slide.
actually, I want to talk about the results here a little bit because
Okay,
somebody
sure,
somebody asked if the prostate will enlarge again over time, right?
sure.
So most studies demonstrate the durability of 5 to 7 years with an approximately 85% response rate, which means 8 to 8.5 out of 10 men will not need anything else, and the prostate is going to stay shrunk basically. But there is about 15 to 20% of prostates out there that can actually grow enough to recruit vessels so that they give symptoms again. And at that point, this procedure can be repeated without any issues actually. And also I like to call it an open door procedure because any other type of minimal invasive surgery or even invasive surgery can be performed. So we're not limiting any other alternative therapies when we do this procedure. And if you want to think, well, why is that? Why does the prostate continue to grow? Well, that's because the human hormonal cycle in males grows on a daily basis. We have a peak of testosterone between 4 a.m. at noon at some point, most of us, for our whole life, And this has to do with a whole um, connection and communication that comes all the way up to the brain and into a testicle. So it's called fancy words are the hypothalamic hypophysis axis, right? So it can grow again. It is not the norm, but it can grow again. Yeah, as you can imagine, it can grow despite of any type of procedure that you do. At 5 to 7 years, with other more invasive surgeries, we see a recurrence rate between 5 and 10%, depending on the type of surgery. So when we compare this recurrence rate of 5 to 10% against the 15 to 20% for prostate artery embolization, accounting for how gentle the procedure is on someone and how well patients do, and for such a long time, and the fact that we don't need general anesthesia to do it. These are advantages that have been popularizing our intervention.
Mhm. Absolutely. We talked about PAE being covered by insurance. You just talked about it can also be repeated and doesn't preclude you from any other treatment in the future. What should I do to prepare? When can how do I get started? Okay, yeah, that maybe set yourself up for a console, and that might also segue us into this slide over here. But let me do this. I think there were a couple questions in the chat. Let me see here if I can pull that up here. Um, Someone wrote, so these are some questions that people left in the chat here. Are there positive impacts on erectile dysfunction? So I don't know about you, Daniel, but I don't advertise that. Now, there are a few studies that go out and say after PAE, erectile function actually improves. And I think some of the ideas are you're blocking off that flow there, so it allows flow to go other places. But I wouldn't count on getting improvement in erectile function after PAE, but you won't leave with worse function than you came in with. Um,
Agreed.
uh, Someone said I arrived late. Do you guys perform a lot of these procedures? Yeah, as I mentioned, across all of our centers, we probably perform about 30,000 of these procedures a year. Does the procedure affect PSA levels? That's a great question. So PSA stands for prostate specific antigen. It's basically a marker that they use as a screening test to evaluate for prostate cancer. Um, but if your prostate enlarges, you're going to produce more PSA to a proportional amount. Um, so when you treat an enlarged prostate, it actually will reduce the PSA once it reaches that steady state at about 3 months. However, it actually will spike that PSA um, about a week after. So that acute phase or that short-term phase where you're having that urinary frequency, that will actually spike. It's normal to be expected. It doesn't cause any issues. But if you were to have it checked at that point, that could happen. And so patients who are on like active surveillance, let's say, it may necessitate less cause for a biopsy because your PSA is generally going to be living at a lower level. Um, Someone said, "Where is the procedure performed?" It's right there in Syracuse, New York. The address is there, 1226 East Water Street in Syracuse. That's right where Dr. Alvarez works. Someone asked
Right.
the question. Yeah, maybe here. Someone asked if under active surveillance with PSA levels, do you need to rule out the possibility of cancer via biopsy before having the procedure? So if you're under active surveillance and you've been steady and you've been meeting all your marks, there's no reason to do a biopsy prior to the PAE. Um, Can the beads migrate? So that was something that Dr. Alvarez was talking about. That's exceedingly rare, that non-target embolization. So there's always a possibility you do everything you set out to do and you do everything perfectly. There's always a chance that these microscopic beads go somewhere you don't intend. In this procedure, the areas where he goes, just like Dr. Alvarez said, could go to the bladder or the bowel. If it went to the bladder or the bowel, you might see blood. In the urine or blood in the stool for a few days, which will resolve on its own. Or if we were to go to the skin, particularly in the pelvis or more specifically the penis, you might have pain, discoloration, even a small ulcerating wound, which would also heal on its own without a secondary intervention. But in theory, those things can happen. They're just exceedingly rare, as you mentioned. Um, there's a few people asking. Um,
Yeah,
patient specific questions here. So for those ones, I'd just encourage you to kind of set up a consult. This one, is there an age limit at like age 80? Can you not do a PAE? Nope. There's no age limit. There's no size limit. There's no shape limit for PAE. Um, do I need to be catheterized before the procedure? Nope. You do not need a penile catheter for the procedure or vast majority of men afterwards. You do not need a catheter. Um,
I would like to just add something here. In
sure.
patients who have had episodes of acute urinary retention recently, I and they, the catheter at some point is removed and they are able to pee again, or if the presentation for the BPH was an episode of acute urinary retention, sometimes I like to recommend actually placing a urinary catheter in a prophylactic fashion so that a new episode of acute retention doesn't happen during that critical period of 1 week after the procedure when things get a little bit inflamed. So you do not need a catheter, but there are certain scenarios in which I would recommend so for selected patients having a catheter placed just to prevent having a hard time
Yeah,
afterwards.
I totally agree. It's much easier, and that's a rare occasion, but it is much easier to get that catheter placed under sedation than having to go into the
Right,
emergency department in the middle of the night and get a catheter placed. But that he's talking about a very rare scenario.
right. Somebody asked regarding um, a biopsy that was negative a year ago. Does that suffice? Yes, typically we would not need to repeat any type of biopsy if to go ahead and do this. We do it to treat the symptoms of BPH. We don't do it for cancer. However, there's like a niche question that I wanted to ask. What I want to Alex to elaborate upon. So sometimes PAE is performed in the setting of cancer. I know it is not used to treat cancer, but why are sometimes some doctors recommending having prostate artery embolization in the setting of cancer?
Yeah, no, that's a great point to bring up. Thanks for mentioning that. Um, so in the setting of prostate cancer, you may be going for radiation for your prostate cancer. And PAE is a great tool that we can use to perform prior to radiation therapy for prostate cancer because it serves a couple purposes. One, it's very common if you have urinary symptoms prior to going for radiation, the symptoms worsen if you don't address it. So it can help with the urinary symptoms that you may have currently or it may even and help reduce the urinary symptoms that you can have afterwards. Secondly, it actually shrinks the prostate, as we talked about, so it can actually reduce the field of view that they have to radiate. So the collateral damage as relates to that would be less. Um, but yeah, I mean, I think this has been a great discussion. I think I really appreciate, or we all appreciate you guys taking time out of your busy schedules to listen to this talk. We're really excited about offering this high level care in upstate New York. Dr. Alvarez, I know is very excited. So if you have any specific questions or anything that you want clarified, I would encourage you to set up a consult with Dr. Alvarez, Dr. Kumar, and Dr. Goldberg. But this presentation will also be emailed to you. Give it about 24 hours, but it would be emailed to you so you can kind of digest and rewind if you like, or just go over the information again. But thanks again. Anything else you'd like to add, Daniel, before we head out?
Yeah, we'll be happy to get on a phone call with you and discuss any details, regardless of your age, your weight, our expertise. We can go about specifics on a case by case scenario.
Right. Well, thank you, everyone. Have a wonderful evening.
Thank you, everyone.